Good evening, everybody, and welcome to Sleep Issues in Children. My name is Karen Koch, and I'm the Director of Mental Health Education at Eastern AHEC. I want to welcome you to this evening's presentation. This webinar series is a part of our Child Mental Health and Primary Care statewide project, which is funded through NC AHEC. This funding allows this series to be offered free to participants from across the state. So without further ado, it is my great pleasure to introduce Dr. Ruth Benca. She's the chair and professor of psychiatry and behavioral medicine at Wake Forest University School of Medicine. She's board certified in sleep medicine and psychiatry by the American Board of Psychiatry and Neurology. She has her PhD in pathology and her medical degree from the University of Chicago. She completed a fellowship in sleep disorders medicine at the University of Chicago. She's a national and international expert in sleep disorders with over 134 papers, 35 book chapters, and a book entitled Sleep Disorders, The Clinician's Guide to Diagnosis and Management. So please welcome Dr. Benca.
Thank you so much. It's a pleasure to be with you today. I'm going to just get my slides up here. So I'm going to be talking today about sleep disorders and sleep problems in children and adolescents. And I think this is a critically important topic in mental health because sleep is really a key component for healthy brain development. Because as we know, our brains don't finish developing until we're about 25 years old, which is why 18 is really not the end of adolescence. And we're increasingly starting to be concerned that one of the reasons or one of the contributing factors to the child and adolescent mental health crisis is the worsening sleep patterns in our children and adolescents. So we'll start by talking about how much sleep kids really need. And you can certainly see from this table from the National Sleep Foundation in terms of recommended sleep amounts that sleep amounts change quite dramatically across childhood and adolescence as the brain develops, and that kids really need a lot of sleep. Even adolescents will need 8 to 10 hours of sleep, and pre-teenagers and younger adolescents may need 9 to 11 hours themselves. So sleep amounts are really critical. Of course, as we age, we need less and less sleep, and we have trouble getting sleep. Typical sleep in, I would say, an adolescent, older child, young adult should look something like this, which is that we have two kinds of sleep. We have non-REM or non-rapid eye movement sleep and REM sleep or rapid eye movement sleep, which is sometimes referred to as dreaming sleep. And when we first go to sleep at night, we enter non-REM sleep and generally our deepest sleep with deep, slow waves, which I'll show you in a moment. And then across the night, we alternate back and forth between periods of non-REM and REM sleep. And each of these cycles is usually around 90 minutes, give or take. And the two trends across the night are that slow wave sleep or deep sleep is more prominent early in the night, and REM sleep periods get longer and more intense later in the night. And that's why, particularly in kids, we notice when they first go to sleep at night, it's really hard to awaken them because they're in very deep non-REM sleep. And then again, dreams later in the night are often more intense and more prolonged because we actually have more REM sleep then. There are sort of two components that regulate our sleep, and this is really important in kids as well as adults, which is that we tend to fall asleep at the beginning of the night because we're sleep deprived. Now, children are generally not awake all day often, particularly younger kids. They may have been napping because their homeostatic sleep drive or the need to sleep builds up very quickly, and they have to dissipate it sometimes several times during the day, certainly when they're babies and toddlers. And then as they get older, may not need to nap as much. But that's why we fall asleep at the beginning of the night, because we've been awake. And then the second part of the night, we stay asleep because our circadian rhythm or our internal clock tells us it's time to sleep. The circadian rhythm actually sends out an alerting signal, which ironically is high in the evening and low in the early morning. So we fall asleep at night because initially we're sleep deprived. We stay asleep because of our circadian rhythm keeping us asleep. We wake up in the morning because we've slept all night. Also increased activation of the hypothalamic pituitary adrenal axis. More cortisol is produced, but mostly we wake up in the morning because we're not sleep deprived anymore. And the second part of the day, we stay awake in the evening because our circadian alerting signal is high. And then we'll talk a little bit more about sleep patterns later. Now, we can also measure sleep by looking at sleep oscillations or brainwave activity. And what I want to point out is that there are two important waveforms in non-REM sleep, slow waves and sleep spindles, which are marked here. So the sleep spindles are 12 to 15 hertz bursts of activity that occur in non-REM sleep, and the deep slow waves are somewhere between usually 1 and 4.5 hertz. The reason this is important is that these are two waveforms that are only normally seen during sleep, and they are increasingly being recognized as being important for some of the functions of sleep, particularly learning and memory and brain plasticity. And then on the bottom, we see an EEG tracing for rapid eye movement or REM sleep. And REM sleep is actually a very activated brain state. And the brain is, in fact, in many areas more activated in REM sleep than it is even during wakefulness. I'm also showing you here on these two headshots what happens when we measure sleep with many electrodes across the entire scalp, and we can actually map out where the brain oscillations are occurring most intensely, because the brain doesn't sleep the same way all over. We tend to think of sleep as sort of a unitary thing. You're asleep or you're awake, you're in non-REM sleep or you're in REM sleep, but even while you're asleep, different parts of your brain sleep differently. And so sleep spindles are very prominent here on the vertex, or sort of the top of the head, because they are driven by the reticular nucleus of the thalamus. And in contrast, slow waves in adults are most prominent in the frontal lobes, because that's where most plasticity is happening during the day. Now, we can actually look at brain development just by mapping out slow waves during sleep. And this is a study that actually just sort of grouped kids in different age ranges and averaged out their slow wave activity. And what we see here is that very young children have the most slow wave activity at the back of their scalp, and really coming from the occipital lobe. And that as they age and enter adolescence, that slow wave activity moves more anteriorly. And that's because the brain develops from back to front, and the frontal lobes are not fully developed until kids pretty much reach, close to the third decade. And some of the work that we've done has suggested that kids who are more actually aerobically fit have more advanced brain development and healthier sleep patterns. So they kind of go together. Now, the other thing that happens across childhood and adolescence is that the preference for being asleep at different times shifts. And that is that young children tend to be early birds. They'll go to sleep early and they'll get up early. They're what we call larks. And then as kids enter adolescence, they start delaying their sleep. They go to bed later and later, and they become more what we call owls. And so they stay up late, and it's really hard to get them up in the morning to go to school, particularly if they stay up really late. And that pattern peaks around the end of the second, beginning of the third decade. And boys tend to be even more delayed on average than girls. Now, there's a lot of individual variability. Not everybody is severely delayed, but from wherever you start, you are the most delayed as an adolescent and a young adult. And then as we get older, we tend to become more morning-like, depending on where we are. And we'll talk more about this tendency to have a delayed sleep pattern in a little bit when we talk about psychiatric disorder. So I want to talk about common sleep disorders or sleep problems in kids. And the number one problem that we all need to be aware of and protect kids against is sleep deprivation. Then we'll talk about sleep apnea, about insomnia and settling disorders, parasomnias, and rhythm disorders. But for those of you who are in the mental health field, and actually in primary care as well, it's important to recognize that sleep problems and sleep disorders are far more prevalent in children with developmental, medical, and behavioral disorders, and particularly developmental and psychiatric disorders. And that's really similar to what we see in adults, that sleep problems are often not only comorbid with psychiatric disorders, but they are predictive of individuals who are likely to go on and develop psychiatric disorders. But we'll start out with insufficient sleep, sleep deprivation, short sleep duration. And this was a CDC survey of kids. And first of all, we look across the country, where are children most sleep deprived? And as we see here, we are close to the region where kids get the least amount of sleep. North Carolina, the data suggests that almost 37, over a third of kids are not getting enough sleep. And as we start going more into the South, those numbers creep up even higher. Almost 50% of kids are not getting enough sleep. We know that children who do not get sufficient hours of sleep are more likely to have accidents and injuries. They're more likely to be obese. And that's true across the lifespan, but certainly in kids as well, because what happens is when you are sleep deprived, there is a dysregulation of the appetitive system such that you start getting really hungry for high reward foods like fats, carbohydrates, salts, all the junk food. And anybody who stayed up late knows you don't start snacking on celery and carrot sticks at 11 o'clock at night. You're going into the freezer for the ice cream and the cookies and all the other stuff. People who have insufficient sleep and children with insufficient sleep are more likely to develop diabetes, probably in part because they're more likely to be overweight and develop metabolic syndrome. They also have problems with mental health, attention, and behavior because, of course, sleep deprivation makes it very hard to pay attention. And then, of course, cognitive development is also impaired. In adolescence, health risks are also concerning. Kids are falling asleep in school. That impairs their learning. And very concerning is that most fall asleep crashes involve young drivers. And that's because they're sleep deprived and they need more sleep. Oftentimes they're driving later at night because that's when they get access to the car. And thirdly, they are more inexperienced as drivers. Again, studies have shown that obesity in children starting as early as 5 and 6 year olds is inversely correlated with sleep amount. So the less sleep 5 and 6 year olds get, the more likely they are to be overweight or obese. And similar results have been reported in many studies in adults and adolescents. Another issue I think that's timely to keep in mind is that kids who get COVID are more likely to have sleep problems. And this was a analysis of sleep disorders or sleep problems in 2 studies of children and adolescents. This was done in China and found that sleep problems were significantly greater in kids who after they had COVID than before. And that also, of course, rates of anxiety, depression, and PTSD were elevated. And we don't know, which is the chicken or the egg, or is their sleep problem higher because they have more psychiatric symptomatology or vice versa, or they're just both going together, but something to be aware of. All right, next, I want to talk about obstructive sleep apnea. And we tend to think about apnea as a problem of overweight, middle-aged, and older men. But we are increasingly seeing rates of sleep apnea in kids that are concerning. So in young children, so pre-adolescent children, most of the epidemiologic studies suggest that 1 to 5%, depending on the population you survey, may have significant obstructive sleep apnea. But kids who are obese, and particularly adolescents who are obese, may have up to a 44% risk of having apnea. Again, the risk factors for obstructive apnea in children, when I started out many hundreds of years ago, it was mostly kids with big tonsils and adenoids because we didn't have such an obesity epidemic. But right now it's really obesity that's driving a lot of this, and oftentimes a combination of enlarged adenotonsillar tissue and obesity. Craniofacial abnormalities are also contributory, and pretty much all kids with Down syndrome at one point or other will likely develop obstructive sleep apnea. Symptoms in kids can be minimal, but typically snoring. They may complain of morning headaches, but behavioral disturbances during the daytime. And it's different than in adults who, may be dozing off in low stimulus situations. Kids with apnea may more likely look hyperactive, irritable, be aggressive. Sometimes they'll have excessive daytime sleepiness, and they may develop enuresis at night. The treatments, of course, are take out the tonsils and adenoids if that's a problem. Continuous positive airway pressure we're increasingly using, particularly because with obese kids, taking the tonsils out is not going to do the trick. And then weight loss as much as possible. We'll talk about insomnia and settling disorders in kids. I think majority of issues with insomnia-related problems in children in general are related to behavioral factors. In adults, we think about predisposing, precipitating, and perpetuating factors. We can also use that construct in kids. So some children are just generally more predisposed to develop or have problems settling and soothing themselves and getting to sleep from an early age. But other factors can worsen that, behavioral things such as having irregular schedules, having too much disruption in the household, kids who will sleep everywhere but where they're supposed to, and parents often sometimes in their best efforts to try to solve their kids' sleep problems end up perpetuating them. We also know from many epidemiologic studies that children who have trouble sleeping may develop lifelong problems if it's not recognized and treated. And again, there's a strong association with behavioral and psychiatric disorders. So kids who have sleep problems are more likely to have behavioral problems. That shouldn't be surprising. First of all, sleep is an important behavior to be able to regulate it. And it sort of seems obvious that if you can't regulate your sleep, it's hard to regulate other behaviors. But more importantly, children who don't sleep that have more dysregulation of kind of behavioral control. So we know that lack of sleep can lead to impulsivity, irritability, mood problems, et cetera, again, contributing to behavioral problems. So just to run through, there have been a lot of studies that have demonstrated both in younger children and adolescents, kids who have sleep problems, have behavioral problems and psychiatric symptoms. We found that a study we did of kids years ago coming in for just well child visits, pre-adolescent children, that those whose parents reported they had insomnia also had a lot of symptoms of anxiety and depression, attentional problems, and somatic complaints. But more concerningly, sleep problems in kids tend to predict psychiatric symptoms later in life. One study looking at very young children, 1, 2, and 4 years old, a large study of over 3,000 children, found that kids who had problems with falling asleep, having nightmares, having restless sleep, were more likely to have ADHD and other psychiatric disorders by the time they were 11. We and others have found that sleep problems early on predict psychiatric problems later in life. And in fact, sometimes the type of sleep problems kids have early are predictive of the type of psychiatric problems they'll have later. So these may be very early symptoms and contributory factors. Another thing to keep in mind, particularly right now where we're having really a psychiatric crisis in children and adolescents, is that insomnia is predictive of increased risk of suicidal behaviors, suicidal ideation, and completed suicides. And we know that suicide is unfortunately the second leading cause of death in young people. And in adolescents, studies have found that kids who sleep less than 8 hours at night or have nightmares or have insomnia are more likely to show evidence of suicidal behaviors or attempt suicide than kids who don't have these sleep problems, even controlling for the level of depression. So it's not because there's an independent contribution, insufficient and disrupted sleep on suicide risk. So it's another reason it's always important to ask about sleep. So how do we treat insomnia in kids? And first and foremost, we really need to do behavioral treatment. I'm not going to really talk too much about pharmacotherapy. Happy to answer questions about that because there are really no FDA-approved agents for use in children. And we use a lot of drugs off-label that are not, some of them not even improved for insomnia. But behavioral treatments can be quite helpful, particularly, this is why it's important to get kids early on into good sleep patterns. So one of the common problems that kids will have is what we call limit setting sleep disorder, which is the children who, stall or refuse to go to bed or refuse to sleep in their own bed. And they, will sometimes say they're afraid of something in the room. There's, a monster in the closet or under the bed or whatever, but they may not really be having an anxiety problem. It's just an excuse not to go to bed. And in response, parents or caregivers are not always enforcing appropriate limits. And when bedtimes are enforced, the kids actually do fall asleep quickly. This is the curtain calls, I need another drink of water or whatever. The other problem, which sometimes can develop secondarily even to the limit setting disorder, and this we see sometimes in very young children and babies, which is what we call sleep-onset association disorder. And that is that these very young children in general rely on an inappropriate association of something they need to be able to fall asleep, such as they need to be feeding, they need to be rocked, they need to be driven around in a car because they need to move, they need to be held by a parent, or they can't fall asleep. And what happens then with these kids is that, parents will, because they're kind of at the end of their wits and they need to get these kids to sleep, will rock the child or sleep with the child or whatever. And then the minute they go away, a little later in the night, the child will wake up and then they have to go through the whole process again. And the problem is, and a lot of these parents will come in and say, my child keeps waking up at night. And the problem is not that the child is waking up, because kids do wake up. Actually, normal humans will often wake up very briefly, as much as several times an hour. We just don't remember because we fall back asleep. But these children wake up and they realize something that I need to go to sleep is no longer here. It's like if you woke up in the middle of the night and someone had taken your pillow away or something that you thought, well, this is not right. I need my pillow back. So that's another problem that will develop. So what do we do about that? There are a different approaches that can be used. I think the one that a lot of parents hear about and some physicians hear about is extinction, which is that you put the kid to bed at the same time every night and you just ignore whatever they do. You just let them scream it out. I generally don't advise that. And certainly when children are brought in to me who are having these problems, parents may have tried this, but they really can't do it. Children are generally stronger than their parents in terms of these bedtime struggles. And the problem, of course, is that when parents try this approach and then they give up intermittently after a while, that's the strongest way to reinforce a behavior, intermittent positive reinforcement. So those kids can always stick it out longer than their parents can. So that generally doesn't work. So another approach is what we call graduated extinction, which is that you ignore the behaviors for a specified amount of time, and then you go and check the child, pat them, whatever, reassure them, and keep, going in and out regularly until the child falls asleep. Another approach is what we call a faded bedtime, which is particularly young children, they simply at some point can't stay up really, really late. And we, anybody who's ever had young kids and, they want to stay up for some special event, and you give in and say, yeah, you can do that. And they conk out because they really can't stay up. So you put the child to bed later than usual, really have them very, almost sleep deprived, and have a brief, enjoyable bedtime routine. And then they learn to fall asleep that way. That's another approach. I'm going to back up. Another thing I like to recommend too, which is sort of a faded or gradual extinction, particularly for kids who, for example, get used to sleeping in their parents' bed or someplace they're not supposed to, or need their parents in their bed with them, is that first and foremost, you always want a child to fall asleep in her or his own bed, not in the living room couch or your bed, and then, carrying them to bed, because then they wake up and they realize they're not where they fell asleep. So you always want them to fall asleep in their bed. And if necessary, start by, maybe sitting at the bedside with them until they fall asleep, and gradually, night by night, move farther and farther away. I use the example of you're sort of doing the opposite of what Jane Goodall did when she tried to get close to the great apes or the chimpanzees. She started by sitting far away and then gradually moving herself closer and closer until they tolerated her. And in this case, you do the opposite. You start very close to the child in their own bed, and you gradually move away, maybe sitting outside the room, and eventually they will be able to fall asleep on their own. And these approaches do work, but you really have to stick to them. Next, parasomnias. Parasomnias are undesirable phenomena that occur during sleep, and we classify them depending on whether they arise out of non-REM sleep or REM sleep. And one that arises out of any stage of sleep, of course, is enuresis or bedwetting. I'm not really going to talk about bedwetting today, but that is is considered a parasomnia. It can occur when a child is drowsy. It can occur in non-REM sleep or REM sleep. The non-REM parasomnias, which are sort of the classic ones that kids tend to have, or disorders of arousal, include things like sleepwalking, confusional arousals, and night terrors or sleep terrors. So sleepwalking or somnambulism is quite common. Up to a half of children will have at least one episode. And in most episodes of sleepwalking, kids are usually calm. This usually peaks in middle childhood or before they're adolescent. And, the typical thing is the kid sort of gets up and wanders and falls asleep somewhere else, on the pile of laundry, on the living room sofa, on the floor somewhere, etc. Or the kids who get up and think they're going to the bathroom and pee in the garbage can or the closet instead of in the toilet, and don't remember anything the next day. The dangerous thing about sleepwalking with kids is they're not awake and alert, and they don't know where they are, what they're doing. And there have been cases where, for example, children in more northern climates may wander out of the house, fall asleep on the back patio in the middle of winter, and freeze to death. There have been cases of that, or injure themselves by tripping over something, or falling out of a bunk bed or something. Confusional arousals are usually accompanied by more intensive autonomic activity. They also can get up and ambulate. The behavior can be bizarre. The child may seem possessed. One of my kids had confusional arousals, and it did look like something out of a horror movie at times. And this also can peak in early childhood. These kids can hurt themselves, particularly if they're agitated. They can, fly out of bed, fall downstairs, run into things. It's very important to make sure they're safe. And the night terrors are a very paroxysmal event. And this is where the child will usually literally bolt upright in bed and sort of scream at the top of their lungs like, someone is murdering them. They may run out of bed and away from perceived threats. And this can occur in older children and even in young adults. Oftentimes, kids will outgrow these parasomnias. Like some of the classic features are that a non-REM parasomnia almost always occurs in the first third of the night, and usually within the first hour or so of falling asleep, because it occurs during the deepest slow wave sleep. And children will have partial or complete amnesia of the episode. They won't remember anything of what happened, and their brain is actually partly asleep. We've done actually some studies on it on young adults who have this problem, and what we are now starting to discover is that some of the motor parts of the brain are awake, whereas frontal lobes are deeply asleep. Children are very difficult to arouse during these episodes, and we generally don't advise waking them up, but rather putting them back to bed. And oftentimes there's a family history. These things seem to be hereditary. Again, kids will often outgrow this, particularly when they become adolescents, because they have less slow wave sleep. The slow wave sleep is most intense before they hit puberty, and then it starts decreasing. However, oftentimes these episodes will persist, and over the years in my clinics, I frequently have parents bring their 17 and 18-year-olds in because they've just graduated from high school and they still have occasional episodes, and they're going to go sleep in a dorm in college. And what are we going to do about it? So again, contributing factors to trigger these episodes are sleep deprivation, because the more sleep deprived you are, the more slow wave sleep you're going to have, and the harder it will be for you to wake up. Any kind of environmental disturbance during sleep can trigger this. So it can be something like a parent tucking a kid in can trigger that, or noise, or something in the environment. Stress, of course. So anything that's going to increase stress levels and contribute to arousals. And for some reason, kids with Tourette's or migraines are more likely to have these episodes. The differential diagnosis is nocturnal seizures. About a third of patients with seizures will only have them during sleep. So if there's any history of self-injury, that should make you concerned that this could be a seizure. Nightmares, we'll talk about in a little bit. Nightmares are, waking up from a frightening dream. Those tend to occur later in the night, and kids are generally not getting up and moving around. Panic attacks, anxiety attacks can be triggered from sleep, and again, can occur early in the night. But children having panic attacks are usually awake and alert. They don't really have amnesia for those events. PTSD can sometimes be associated with paroxysmal arousals, and there are other parasomnias as well. So nocturnal seizures, in contrast to non-REM parasomnias, can occur at any time of night. They're not precipitated by sensory input, so tucking a child in will not cause a seizure. They more often will have stereotypic behaviors and may not have a family history of parasomnia. So how do we diagnose these? Usually by careful history, but sometimes we'll do sleep studies in these kids, and in cases where there's any suggestion of any self-injury, violent behaviors, daytime sleepiness, frequent attacks, unusual features, then send them over to the sleep clinic for further assessment. The most important treatment is safety precautions, make sure that children can't harm themselves, fall out of beds. Bunk beds are not advised. Make sure they can't get out of windows, fall downstairs. Don't lock children in rooms ever because of there's a fire. They may not be able to get out, but do use an alarm system if you need to. Get them that hook on the door, or a pad that child steps out of bed or out of the room that parents can be awakened. Also, key is to make sure children get sufficient hours of sleep, that they're not overly stimulated prior to sleep. And sometimes we use medications. Medications, again, these are not necessarily FDA approved because nothing is FDA approved for parasomnias, but either low doses of a benzodiazepine such as clonazepam, low doses of tricyclic antidepressants sometimes are used. If you're going to start medication, we generally recommend those are kids, if it's bad enough to start a med, that we should probably study them first. And sometimes after getting control over the symptoms, medications may be able to be tapered and discontinued. Another parasomnia in kids that occurs in non-REM sleep is a rhythmic movement disorder. And there are different forms. Head banging is the most common. And this often starts in very young kids, even in their cribs, where they kind of bash their heads on the side of the crib or on the wall. A head rolling, where a child rolls their head from side to side. Body rocking. Kids can sometimes get up on all fours and rock back and forth. These episodes generally occur at transitions into sleep, usually at the beginning or end of sleep, and maybe during light stages of sleep. And sometimes they're accompanied by vocalization, rhythmic vocalization. And again, they almost always begin in very young kids before the age of 2. And they are seen at greater frequency in kids who have developmental disorders, seizures, and other neurologic disorders. Usually, we sort of let kids outgrow them. They can be treated by sleep restriction. So again, a kid who is put to sleep who has this disorder, who's not really that sleepy yet, will engage in these behaviors sort of as a self-soothing mechanism. So one thing is to sort of sleep restrict them, put them to bed a bit later, so they fall asleep more quickly. There are other behavioral therapies that can be used. Medications are not necessarily terribly successful. And in some children I've seen who have really severe head banging disorders and sometimes are developmentally delayed, we may actually have to put helmets on them to protect their head. Restless legs, again, we more typically associate with adults, but it can occur in children and start in early childhood and is often misdiagnosed as growing pains because kids will complain of discomfort in their legs, have an urge to move their legs, have very restless sleep. Again, this can be familial, but it also can be related to iron deficiency. And certainly any child who reports restlessness or restless legs, and restless legs not only occur in bed at night, but they can occur when you have to sit still for long periods of time. So I every so often have seen kids who have been treated for ADHD because it's assumed they're hyperactive because they can't sit still and they're fidgety whenever they're sitting. And sometimes they've been put on, high doses of stimulants with no benefit. And it turns out that sometimes they're just really horribly iron deficient. So, and just replacing iron will be helpful in these kids. In adults, we do things like dopamine agonists and benzodiazepines, but I've rarely had to do that in children. Again, it's usually an iron deficiency issue or a side effect to maybe other medications they're getting. All right, now we're going to talk about delayed sleep phase. These are the night owls. We talked about that earlier. Adolescents in general tend to be kind of night owlish. They like to go to bed later and they don't like to get up in the morning. And in some children, this can become very severe, characterized by difficulty falling asleep until hours and hours after the desired bedtime, and then really impossible to get them up in the morning. And in severe cases, these kids just don't get to school. because parents can't get them up. This is a disorder that usually appears in adolescence because that's when we see these developmental changes in sleep. Sleep need, actually increases, is high in puberty. So the other issue is, children need to get enough sleep, and they tend to face delay, and early school start times are exacerbating this. The other thing to keep in mind, particularly in children who really have a lot of problems with this, is that it is often associated with mood disorders and other major psychiatric disorders. And in genetic studies that have been done, we see that patients who tend to have bipolar disorders, mood disorders, and other major psychiatric disorders often have abnormalities in their circadian genes that predispose them to have a delayed sleep phase. And the other thing is both delayed sleep phase as well as insomnia are associated with increased suicidal risk in adolescents. So if you've got a kid who's really delayed, it's really important to screen them for psychiatric problems and to screen them for suicide. Again, altered clock genes in these disorders, and people and adolescents as well who are prone to bipolar disorder, schizophrenia, are more evening types, also more seasonal. So people who, and in general, not just adolescents, but people who are more evening types tend to be more seasonal, meaning that, sort of more this winter pattern of fatigue, more sleepiness, increased appetite, sort of the opposite in the summer, and disrupted circadian rhythms. This is what happened. It's a study that was done about 15 years ago now, but I think a lot of our schools really have not adjusted to this data. And this is what happens to, on the top, bedtime in girls and boys on weekdays and weekends by age across the x-axis. And what you see is that between the ages of 10 and 17, kids go to sleep later, both on weekdays and particularly on weekends. But on the bottom, we see what time do they wake up. And you see this big drop in terms of what time they have to wake up in the morning, starting about age 14 when they have to go to high school. But the weekend, they're getting up later and later as they hit adolescence. And we call this difference in wake up time in the morning between weekdays and weekends as social jet lag. And kids who have a discrepancy of 2, 3, or 4 hours or more in their wake up time between weekdays and weekends are more prone to have psychiatric issues, not do well in school, etc. And this is why a lot of us in the sleep field are, advocating for delayed school start times as kids enter adolescence. So how do we evaluate and treat this? Well, first of all, we get a complete history, medical, psychiatric, and sleep, because these kids are more prone to psychiatric disorders, and keep a careful sleep log. Have recordings for several weeks of what time do they go to bed, what time do they get up. And the treatment is to first and foremost stabilize their sleep schedule. And I like to start with a schedule that they really can adhere to begin with, because if they don't start with a stable schedule, we can't move it. And then we do behavioral therapies to advance their sleep. Sorry, that sleep is misspelled there. I'm not going to talk about chronotherapy because I don't advise that. We don't do that anymore. But we do interventions to phase advance their sleep. And the phase advancing techniques are to expose them for bright light early in the morning. And that's a light box that gives out somewhere between 5,000 and 10,000 lux, and try to expose them to that for at least 30 minutes as early in the morning as possible, because bright light is what's setting our clock. Morning exercise is often helpful as well. So for high school kids, try to see if they can get their gym class scheduled first thing in the morning. Low dose melatonin taken several hours before bedtime, not right at bedtime, or at least 8 hours after waking up in the morning, that gives the brain a signal that night is coming and let's get ready to sleep. Avoiding bright light and exercise late in the day, and to remember that light resets rhythms in a phase-dependent manner. So if you get exposed to light late in the day, it pushes you later, makes you more of a night owl because your brain thinks, oh, it's still light out, I should still be awake. And if you are exposed to light in the morning, it pulls your phase earlier because it's telling your brain day is starting earlier. You better kind of get with the program here and get up earlier. What we want to be careful about is not being exposed to light in the middle of the night because some strange things can happen in terms of pushing the rhythm the wrong way. Other considerations for kids who have delayed sleep phase is to really try to avoid after school or evening jobs or activities that will keep them staying up late. Arrange delayed school start time in severe cases. And as I mentioned, schedule their physical education classes early in the day if possible. And I'm going to stop there and we have some time for questions.
First question is, can you address night terrors, especially in the 5 to 7-year-olds? What exactly is it? Will they outgrow it? What is the treatment for night terrors?
So night terrors this is when the kid sort of sits bolt upright and screams and, thinks there's something horrible going on. Often it's accompanied with some kind of dreamlike mentation. They may claim they saw something or something was attacking them. Reassuring a child, putting them back to sleep. They often don't remember it the next day. And if it's not extreme, it's just happening from time to time. Often things like making sure the child isn't sleep deprived, making sure they're not overstimulated before bedtime, will be sufficient. Otherwise, you can do some of the same things that we recommend for any of the other non-REM parasomnias. If it's really severe, like a low dose of a tricyclic like imipramine, a low dose of a benzodiazepine like clonazepam, we can try those. I suppose you could try melatonin. All of this is off-label, and it's really just a matter of trying to find a treatment that's not worse than the disease for the child. But again, environmental protection, no sleep deprivation, behavioral approaches are what we always want to start with.
Thank you, Dr. Benca. The second question we have is, at what age is melatonin safe to use in children and at what dose?
Great question. There's not a lot of evidence that melatonin is harmful even to young children. Obviously, they have to be able to swallow it. If we're using melatonin, particularly for phase shifting, we don't necessarily need to use high doses. I mean, we know that in adults, 1/10 of a milligram given at the right time can have an impact. I would generally start at, the lowest dose, like 1 milligram. And again, if you're using it for sleep, it's the data on how much it helps sleep per se as a sleep inducing agent is mixed. There are some people who do get sleepy from melatonin, but not everybody. It is probably more useful as a circadian rhythm and training signal. And again, for that, we want to give it a little bit before bedtime because generally your brain starts producing melatonin several hours before your actual sleep time. So that's where we find that it's most helpful to use it if we're trying to, establish a more regular sleep pattern. But in terms of giving medications to kids who are having trouble sleeping, melatonin is probably one of the safest things that you can try. One place where I don't advise using melatonin or high doses of melatonin is in people during reproductive stages of their lives, because we know that in many mammals, melatonin secretion not only kind of tells your brain how long the night is and sort of helps you adjust to seasonal patterns, but it also regulates reproduction in many animals. So probably better to avoid certainly high doses in those groups, but that's not what we're hopefully dealing with children and adolescents.
Excellent. We also have another question about melatonin. What are your thoughts on the use of melatonin in normally developing children who have bedtime struggles related to poor sleep habits rather than a developmental or neurological issue?
Well, if they're having struggles at bedtime, I strongly recommend behavioral approaches. I'm not sure melatonin is going to do a whole lot. I mean, if you give them a little bit of melatonin and it helps, that's great. It might even be a placebo effect, but those are children that really need behavioral approaches, whether it's positive reinforcement or just strict limit setting, or fated bedtime, putting them to bed later so they fall asleep, and then just gradually moving that earlier, whatever it takes. But that's usually the most effective treatment long term if it's done consistently. The other thing, I mean, I'll talk a little bit about some of the work we've been doing over the years, and I think this is important because again, I just want to emphasize the importance of sleep for healthy brain development. And we're finding, and we've done some even looking at sleep patterns starting in pregnancy. So we know that moms who don't sleep well while they're pregnant, controlling for their level of depression while they're pregnant, are more likely to have sleep problems after they deliver, and depression. They're more likely to develop depression. But what we're also finding is that when mothers don't sleep well, either while they're pregnant and certainly during the first year of the child's life, those kids don't sleep as well. And we don't know if that's hereditary or developmental, and then when those children don't sleep well during the first year of life, they're more likely to go on and continue to have sleep problems. So from a sort of children's health standpoint, it's really really important to intervene early when kids have sleep problems, because these are sort of self-perpetuating issues and are really impacting on the development of brains at a very critical time.